Welcome to She Persisted. I'm your host, Sadie Sutton, a 19-year-old from the Bay Area studying psychology at the University of Pennsylvania. She Persisted is the teen mental health podcast made for teenagers by a teen. In each episode, I'll bring you authentic, accessible, and relatable conversations about every aspect of mental wellness. You can expect evidence-based teen-approved resources, coping skills, including lots of DBT, insights, and education in each piece of content you consume. She Persisted offers you a safe space to feel validated and understood in your struggle, while encouraging you to take ownership of your journey and build your life worth living. So let's dive in. This week on She Persisted.
Self-reflection is a two-edged sword. It's good to be paying attention to what's going on in your life. I think where people get stuck, at least the folks we usually see clinically, they've gotten into blaming themselves for things that have gone wrong. As opposed to, I didn't study hard enough for the test, or as opposed to, most relationships are practice relationships and you get better with practice, etc. We take it to heart and we blame ourselves. We think we're unlovable or we think we're incompetent when that's not the case.
Hello, and welcome back to another episode of She Persisted. I'm so excited you guys are here today. It's officially final season. Yesterday was my last day of class, so things are busy. We're a little bit stressed. So many things on the calendar on a day-to-day basis. During final season, you guys know I'm really sensitive with my sleep schedule. It's like my number one non-negotiable when it comes to my mental health, and I always like to take a proactive approach, and so I know during finals I have less flexibility with when I can be sleeping. Not that I'm not getting enough sleep, but it's definitely more limited than it is usually. I don't have as much flexibility, and that also means I have to be really cognizant about my caffeine intake. Like, I want to be drinking more coffee because I feel a little bit more tired, but I also don't want that recurring cycle of being exhausted, drinking a bunch of caffeine, and then I'm not able to fall asleep that night, which is why I am partnering with Magic Mind, and I'm officially a Magic Mind ambassador. I wanted to share this with you guys because it is one of the best finals hacks I have come across. I gave a bunch to my best friend. She drank them all. We are obsessed. It is a great trick to add to your toolkit during finals or during any stressful periods of your life when you're a little bit more tired and don't want to overdo it on the caffeine, especially if you're anxiety prone, because caffeine can just make all of that worse. So Magic Mind is a mental performance shot. It helps with having a sharper mind, lower stress, and calmer energy. And if you guys are not aware, matcha is, in theory, better as a energizing beverage than coffee is. Like tea, the general consensus is that it's better for the brain, for the body. I cannot do the taste of matcha. I've tried so many times to do like an iced vanilla matcha, and to me it tastes like grass. I just can't do it, but I wanted the benefits, and so this is the best hack and solution. It's just a little shot and it's flavored with passion fruit, which is one of my absolute favorite flavors. And also in the formula is lion's mane, bacopa, and cognizant for mental performance, ashwagandha, L-theanine, and turmeric for less stress, rhodiola, cordyceps, and matcha for calm energy, and vitamins B2, B3, B12, BC, and D for vitality. So it is the best additive to your routine when you don't want to overdo it on the caffeine. You know that your baseline is a little bit more stressed and overwhelmed, maybe a little bit more anxious, and you want an alternative to extra cups of coffee. So this has been a non-negotiable in my morning routine during final season. I'm sure it will be for you guys as well. You can shop Magic Mind at magicmind.co/shepersisted20, and you can get up to 48% off your subscription with code shepersisted20. So all of that will be in the show notes, but magicmind.com/shepersisted20, and use code shepersisted20 for 20% off a one-time purchase and 48% off subscriptions. So in addition to finals, it has been very busy because I just went to ABCT, which is also known as the Association for Behavioral and Cognitive Therapies. It is a huge convention. This year it was in Philadelphia, and so a ton of clinicians and researchers all gather to talk about what's going on in the field, talk about new research. I went to a bunch of panels on social media and mental health. I went to a bunch of panels on depression. It was really incredibly interesting, and I was so excited because I had recorded with Dr. Hollon, who's this week's guest, before ABCT, so I got to go meet him IRL and hear him talk with a bunch of other really incredible clinicians and build on this conversation that we had. But if you're not familiar with ABCT or CBT or Dr. Hollon's research, Dr. Stephen Hollon is a professor at Vanderbilt. He's at the forefront of depression research. He's an extremely prominent researcher within the field, and his research is on how behavioral interventions can treat depression. So how that can be an alternative and sometimes even more effective than antidepressants, which typically are like that frontline approach, that first line intervention for depressive symptoms. So to give you guys a little overview, because this is a more research-related episode, we're going to talk about why Dr. Hollon became interested in this area of research. We talk about how many people actually struggle with depression, like how much of the general population actually gets depressed. We talk about his perspective on how we should be viewing the mental health crisis that we're in. We talk about self-reflecting on depression and what most people get wrong. We then dive into the evolutionary mechanisms behind our symptoms of depression. Like, depression serves a purpose. Obviously, we live in a very different environment than the one that we evolved for, which is like caveman days. So what is depression trying to tell us that maybe the message isn't getting clear because we live in a different context now? We talk about different interventions other than antidepressants that are effective in treating depression and that the research shows that they really work. We talk about how changing your thoughts and behaviors through CBT can affect depression. So your quick little TLDR on CBT is that there's this cycle of thoughts, emotions, and behaviors. And your emotions impact your thoughts, and your thoughts impact your behaviors, and it's a continued cycle. And the idea is that when we experience a lot of distress, when we're depressed, when we're anxious, when we're not able to function in our day-to-day lives effectively, something with the way that we're behaving or thinking isn't going as effectively as it could. So how can we intervene and adjust that cycle? And with CBT comes exposure therapy and behavioral activation, and we'll get into some of those in this episode. But that's your CBT, is like the triangle, and how can we change our thoughts and behaviors to shift our emotions. Then Dr. Hollon and I talk about what makes some people more likely to get depressed over and over again rather than just experience depression one time. We talk about why adolescents are more vulnerable to depression, which is really interesting, one of my favorite topics to touch on. We talk about 2 things you can do to stop a depressive episode. And lastly, we talk about trusting adolescents to make positive changes for their mental health. This was one of my favorite episodes to date. Again, I'm giving you the warning that it's a lot of research, but you guys are going to enjoy it, and it's so relevant and impactful. And I'm so grateful to Dr. Hollon for taking the time to sit down with me, and it was great to get to meet him at ABCT. So I hope you guys enjoy this conversation. I will be getting back to studying for finals. And with that, I hope you guys have a great week. I will see you on Monday for a mini episode. As always, make sure to share with a friend or family member, post on social media, tag me. I'll make sure to repost. I really appreciate you guys. We're almost at the end of the year, and we just did Spotify Wrapped, and it was so cool to see how many new listeners we have here, how many people from different areas of the world are tuning in, what episodes you guys like the best. So loved seeing that. So appreciative, you guys. And I'm going to stop yapping so we can get into this conversation. So let's dive in. Well, thank you so much for joining me today on She Persisted. I'm so excited to have you on the podcast. We know how many young adults struggle with mental health, but there's this really, really big gap between the research that's happening and what we know about depression and anxiety, and then what teens are aware of when they start struggling or when they have a friend or a family member going through it. And so I'm hoping we can lift the curtain a little bit in an accessible way. And I'm just really grateful that you're taking the time for this conversation.
Please. Thank you.
So to give people a little bit of a background, if they're not in undergrad studying psychology and really into reading all of the literature, what made you want to study depression and these different mechanisms and symptoms that are associated and dig deeper? What drew your interest?
Yeah, for whatever reason, I've been interested in depression for as long as I can remember. Never paid much attention to the Bible, but the book of Job I thought was interesting. The most gracious of all men could be tormented by God. And it's kind of in the family. I've had my own episodes of depression in the past. My father did, and it was just always seemed interesting to me. Lincoln, Churchill, some of my favorite people have histories of depression.
Yeah. It's something that impacts so many people. And I think what's also really interesting about it is, like, when we think of those people and they come to mind, we don't think the first thing about them is that they're depressed. But when we're experiencing it ourselves, it's so different. It often is like, that's the biggest part of my life, or this is such a crucial part of my identity. And so in so many aspects, there's that huge double standard.
Yes, very much, very true.
Yeah. So how I came across your work is I am a member of a lab at the University of Michigan, and the PI actually came on the podcast, and he's doing research about how we think about depression. So like if we think about the chemical imbalance theory versus it's a signal, how does that impact how much people engage in treatment and then their outcomes? And so we read your paper about what we got wrong about depression and as a field, what maybe hasn't been as effective. And I think, again, there's this gap. So a lot of the things that you mentioned, maybe people aren't seeing a difference yet when it comes to intervention or going to therapy or getting support. And so I was wondering if you could speak to us in your career what you have noticed first about like things maybe we haven't gotten totally right, and then also if there's things where you're like, I think that's accurate, I think that's valid from the research side.
Yeah, sure. Happy to do that. There are a couple things. Number one, depression, at least unipolar, non-psychotic unipolar depression, is a lot more common than we were aware of before. And if you do the retrospective epidemiological studies, the estimates still make it a very common clinical disorder. About 16% of the population, 20% of women, 12% of men are going to have one or more major episodes of major depression in their lifetime. Again, non-psychotic, unipolar. It turns out that's about 3 to 5 times lower than the actual base rates. If you follow a cohort from birth on or across the course of adolescence, which is where it usually kicks in for people, what you find is the rates are well over 50%. For example, the Dunedin cohort study, birth cohort study, and folks are just in their 40s now, mid 40s, and already more than half of the folks in the sample have had depressions. And the other thing that we weren't prepared for, we've always assumed that depression was quite recurrent. If you have one depression, you're going to have a series of multiple episodes. Turns out that's not true either. It turns out for most folks, they're going to have 1 or 2 episodes in their life in response to really bad things that happen to them. You lose a loved one, you lose a job that you really cared about, you don't get into medical school, whatever that may happen to be. But most folks aren't going to have a lot of depressions. A smaller subset of people, probably the 15 to 16%, are the ones that have multiple episodes. And those are the ones that end up coming in for treatment. And those are the folks we really study. So we've gotten a biased look at what depression is really like. It's so common, you almost talk about it as being species typical. Anybody can get anxious, anybody can get angry, and virtually anybody can get depressed.
What are your thoughts on we are like in the mental health crisis? There's a lot of this messaging that that's a bad thing if this is species typical and that this is a shift from like 50 years ago, 100 years ago. Do you think it's really that non-judgmental approach of like this is something we struggle with and we can adapt accordingly, or you're like we're on a bad trajectory, this is an issue, we got to shift?
Well, I think it's something that we can understand. I think we can deal with. I think I think it's almost a bit of a growth experience. All that being said, I think the last thing you want to do for people coming into adolescence is cut them off from their friends. 14, 15-year-olds, all the way with the 14, 15-year-olds not locked away on the internet because they can't go out in public. So I think the notion that rates are up is true, but that's the last thing you want to do to young teens.
Yeah.
And I think that's elevated the rates of depression. But it's almost a sense of isolation. I do think that if you don't take it the wrong way, if you don't interpret it as a sign of weakness as much as part of a developmental process that ideally get a chance to go through, then you don't take it as quite as seriously.
Yeah, it also gives you a lot of empathy for, like you mentioned, these big life experiences, whether it's grief or being
Mm.
rejected. Like we all have that happen. And if we didn't, we wouldn't understand those intense, large emotions. And we know, like you mentioned, relationships are so important for everything. So
Yep.
having that emotional experience, although incredibly uncomfortable, it in turn will strengthen those other relationships down the line.
I think you're absolutely right. It's a miserable experience to go through. On the other hand, anxiety keeps you safe, pain keeps you from damaging already injured tissues, and depression keeps you thinking carefully and seriously about the things that are important in your life. And that's not a bad thing to happen.
Yeah. I'm sure this will get into a little bit of the intervention and CBT side of things, but ideally you would experience a down day, a couple of days, maybe it's a couple of weeks, and you'd be like, I have to think about this. Something in my life isn't going correctly. But I think a lot of people run into a wall. Either there's not that awareness that like I'm depressed and not that you shouldn't feel that way, but like how can I shift my
Yeah,
behaviors and emotions?
yeah, yeah.
What do you do when people aren't having that self-reflection or they're not able to make those changes around them?
Yeah, I think, and again, I could be wrong here, but I think that self-reflection is a two-edged sword. It's good to be paying attention to what's going on in your life. I think where people get stuck, at least the folks we usually see clinically, they've gotten into blaming themselves for things that have gone wrong.
Yeah.
As opposed to I didn't study hard enough for the test, or as opposed to most relationships are practice relationships, and you get better with practice, etc. We take it to heart and we blame ourselves. We think we're unlovable or we think we're incompetent when that's not the case. So what we try to do with somebody who's clinically depressed is get them testing that out. Consider what kind of behavioral experiments they could run. If you've had a bad experience in a relationship, try other kind of relationships or other additional relationships and see if it's really true that you're unlovable, or we just went about the last one the wrong way. If you're not getting what you want out of your profession or job, career pursuits, etc., try a little harder, try something different. But it's usually not the case that people are accurate when they make a global, stable internal attribution to some defect in themselves. It's usually something in their behavior, and they can
Mm-hmm.
work that out.
Yeah. Do you think that's something that we are learning from a societal perspective, or do you think that's more internal? I'm sure the CBT process is reinforcing it when we think about like the behaviors and the cognitions and the thoughts we're having. It just becomes like a self-repeating cycle. But where do you
Well,
think that stems from for
well, I,
specific
I think we're
people?
wired up for that.
Okay.
Gotten very much interested in the evolutionary perspective, in particular this fellow Paul Andrews at McMaster. He might
Yeah.
find interest at some point. But no evolutionary biologist would think about anxiety, pain, or depression as being aberrations. They would think of them as being evolved adaptations that served a purpose. And what they would do is follow the energy. It's like in political scandals, you follow the money. They would follow the energy. And if you've got an infection, the energy goes to the immune system. You don't want to date, you don't want to think, you're not interested in food. If you're starving, the energy goes to foraging for food and preserving the vital organs. If you're clinically depressed, the energy goes to the cortex. And the energy goes to really thinking long and hard and carefully about whatever's going on in your life. And that, again, that's probably not a bad thing to do from time to time. You don't want to make a
Yeah.
habit of it, but it's not a bad thing to do. What I think we do clinically in something like cognitive therapy is help somebody get unstuck when they focused on some defect in the self, which usually is not there as being the core problem.
Yeah.
And so that's where I think that goes. But I think we're wired up to think carefully about things when we get depressed.
Yeah. We have these other really interesting mechanisms, like we're motivated to withdraw, even though being with people would be more effective. You mentioned self reflection, even though maybe a little bit less would be more beneficial. There's all these other interesting, you're eating more, you're eating less, you're sleeping a lot, you're more irritable and pushing people away. Are there any other mechanisms of depression that potentially have these evolutionary stems that offer a lot of validation and compassion and like, okay, this is not crazy to people that are struggling?
Right. Well, some of the things you just mentioned, for example, the withdrawal, the loss of appetite, etc., predate human beings. They predate
Mm-hmm.
the cortex. You can get mollusks without much cortex that do those things. That's part of our older immune response. And probably
Okay.
whatever goes on to depression grew out of the way we dealt with infections. So things that would conserve energy were still there. What's new for human beings is the cortex getting involved and really trying to
Okay.
solve problems. So again, I hate to see folks get stuck. And I can remember the couple of times in my life when I got stuck, but it was usually when I was able to start thinking about what steps I would take to arrive at a change, what was going on in my life that I did. That's when I got unstuck. And I think
Mm-hmm.
that's what we basically do, at least in a cognitive behavioral approach to treating depression. Yeah.
If people, we're going to get into all the things about CBT and why that can be so effective. If people aren't working with a CBT therapist, or if this is their first exposure to that and they're like, okay, I'm curious, I want to learn more, what does that specific process look like to think less, ruminate less, be in that cortex less
Yeah.
intensively?
Yeah, that's a great question. A couple things. There are self-help manuals out there. Dennis Greenberg and Chris Podesky have one of the best. I think it's called Mind Over Mood, and it lays out what you might do with the therapist without the therapist. There are websites that you can go to. You get a little cautious there because it's like the Wild West, and some are, some
It's
aren't.
true.
You can do those kinds of things, and it looks to be the case that there's not much you can do with the therapist that you can't do on your own, but especially if you have somebody working with a trainer that you're accountable to. You can
Mm-hmm.
do unguided websites, but it works a little better if you have somebody that you have to report back to, even if they're not necessarily therapists. So there
Mm-hmm.
are a lot of options now that we have. The
Yeah.
other thing to mention is cognitive therapy, cognitive behavior therapies are quite generally pretty useful. They have long-term enduring effects, so they seem to reduce risk for subsequent episodes, but they're not the only ones that work. There's a simpler behavioral activation approach, which doesn't pay attention to cognition at all, but seems to work about as well. It's not been tested as often, but it's held well when it has been tested and might have an enduring effect. Interpersonal psychotherapy works quite nicely. The variety of psychological interventions that do seem to work pretty regularly, pretty reasonably. And the antidepressant medications, they're much safer than what we had 20, 30 years ago. I have concerns about long-term reliance on medications because they don't have enduring effects. And there's some reason to think, and I go back to somebody like Andrews and the evolutionary perspective, that they might actually suppress symptoms at the expense of leaving you at risk. At any point you try to stop, you're going to be dropped right back in the middle of an episode. So long term, I would prefer to see people have other options. A lot of these things work to take the edge off it.
Yeah. Will you elaborate on behavioral activation and what that looks like in the context of depression?
Yeah, what we would do in something like cognitive therapy, which of course came out of Philadelphia, came out of psychiatry.
Yeah.
But but what we do in cognitive therapy is to get people to use their own behaviors to test the accuracy of their beliefs.
Hmm.
If, for example, you don't think you'd enjoy the party, go to the party and find out. Now,
Hmm.
it turns out that most folks enjoy the parties more than they thought they would. Depression is, to use a phrase, is a disease of expectation and recollection. It lives in
Hmm.
the future, it lives in the past. At the moment, it's not that you can't enjoy, it's that you don't think you will, and you remember it differently after the fact. But we'll get people to run those kinds of experiments. If you don't think that you can get into a school that you'd like to go to, apply anyway and see what happens. Apply to a bunch of schools and see what happens. Sometimes you surprise yourself. Somebody who's depressed tends to turn a low probability into a no probability. If I talk
Hmm.
with an undergraduate about going on to medical school or graduate school, they say, well, the chances are only about 1 in 10. If they're depressed, they think that means don't apply, as opposed to applying to 20 and you
Yeah.
pick a few. And then especially when it comes down to things like the notion of if you have a bad relationship breakup and you think it must be something about me, there may be things you did that didn't work well. You want to pay attention to that because you can change those. But if the notion is somehow I'm basically unlovable, try additional relationships. And they're not all going to work. Some will, some won't. And it's a matter of taste. Same thing with jobs, same thing with careers. Yeah.
How does that process evolve once you add in the thoughts element?
Yeah, two things. In behavioral activation or the behavioral activation component of CBT, don't wait to feel like doing something. Do what you would do if you weren't depressed and see how it turns out.
Hmm.
And the cognitive element is don't believe everything you think. And what we'll do in cognitive therapy is try to encourage people to check out how accurate their beliefs are. There's almost kind of a mantra we try to encourage people to lock away on. One is, what's my evidence for that belief? Any alternative explanation than the one I just came up with? And third, what are the real implications? And usually one or more of those three questions are going to help you sort out that I don't know exactly what it is yet. Let me run an experiment and see where it's going to go.
Hmm. You mentioned in the What We Got Wrong About Depression paper, and you mentioned this at the beginning, that there's some people that maybe never experience a depression. There's some that maybe have an episode in response to a big life event. And then there's others that are, I don't know if more prone would be the right phrase, but they have these multi episodes.
Yeah, yeah.
What make me feel more likely to fit in that bucket?
Well, maybe so. The folks that we typically see in clinical settings have multiple recurrences. Most folks who get depressed don't have multiple recurrences. That's one of the
Yeah.
we're just finding out. Then the question is, what makes the folks that have multiple recurrences different from the folks that don't? And there are a host of things that may be going on. There may be some bit of genetics involved, although unipolar depression is not particularly heritable. It's less heritable than political preference. It doesn't mean that particularly people that have early onsets may have a little bit more of a genetic loading. It may be that people that have histories of childhood trauma are a little more likely to get depressed. There's a curious aspect here. In our evolutionary past, depression seems to not show up much in pre-adolescence, but it kicks in adolescence.
Hmm.
So if somebody's going to have a lifetime course of depression or even multiple recurrences, usually about half or more of those folks are going to have their first episode when they're adolescents. It may not get treated, but it may be the kind of thing that they remember. And in our evolutionary past, that's when our species became reproductively capable. That's when you had to worry about sex, the other gender, and getting pregnant. And unipolar depression is twice as common in women as in men. And when you start thinking about maybe what we're doing here is having more cortical involvement to solve problems, nothing's more problematic to a young adolescent than relationships. So
Yeah.
it's exactly the time you want to be able to think carefully about stuff. So
Mm.
that may not be a bad thing.
So that interesting period, not necessarily pre-adolescence, but adolescence,
Lessons.
potentially longitudinally follows this pattern. Is there anything else about that time frame or that time period that you think either environmentally is that additional stressor, or the way we're thinking about things, rejection is definitely heightened? Any thoughts there?
That's when we outgrow our families. My wife's a developmental psychopathologist, works with particularly with adolescents,
Hmm.
and that's about the time that reality becomes what your friends think it is.
Yeah.
And 11, 12, 13, nothing's more important to us than how we think we fit in with our friends, with our peers. And you can sometimes get a little stuck, a little over concerned about that. But there's a lot of drama, and understandably, but it's where you're sorting out who you are, how you get along with other people, and it's going to be a time of testing your own independence. Yeah.
Yeah. I'd love your thoughts right now. A big theory floating around about why that period is tough is social media and phones have exacerbated issues with regard to mental health, especially in girls.
Yeah.
Do
Yeah.
you buy into that? Do you have other thoughts?
I don't know for sure. Rates have
Yeah.
gone up, and
Hmm.
it's hard to say exactly why rates have gone up, but they started going up even before the pandemic.
Yeah.
Certainly, the isolation of the pandemic made it even worse. My understanding is that junior high school is a cruel time for anybody, but if you can get unliked and like, I don't know all the thing that happens on the internet, but a lot of stuff happens on the internet.
Yeah.
And I've got two young granddaughters. I kind of hope they get protected from that. Right now, they just
Yeah.
want Disney princess films, but God, things are going to get worse in a couple of years. Yeah.
Yeah, yeah. We were talking about thinking about things too much. It's like the internet feeds into that because it's not like you see your friends at school and maybe you see them across the lunchroom and you're like, they're talking to that person or they're not engaging with me. It's like they're not responding to my Snapchat, but I know they're online and I see them on Instagram. Dude, there's so much more information.
So much more information, and it's readily accessible. And I think it's easier to be cruel on the internet than it is in person. But I could
Mm-hmm.
be wrong.
For people that have experienced depression in adolescence and they're like, okay, maybe potentially this might pop up again later in life, is there anything that you would recommend they do at this point in young adulthood
Yeah.
to build that skill set, think about this differently?
Again, the two major things, and one's that the straight behavioral activation component, which is
Mm-hmm.
don't wait to feel like doing something. If you would have done it,
Yeah.
if you were depressed, do that anyway. Make yourself do that and
Mm-hmm.
see where it goes. You can get things moving more rapidly. And then cognitively, don't believe everything you think. Just because you think it's true, particularly if you're in a bad mood, doesn't mean it is true. Check those two things out. Relatively
Absolutely.
straightforward. Interpersonal psychotherapy has some really good strategies for building relationship, et cetera. And I don't want to short shrift them. It's another very effective clinical intervention.
Mm-hmm.
And
Mm-hmm.
all good stuff. Yeah.
I'm curious to get towards the end of our conversation what you hope to see in the field of depression research, what different areas you're curious about in the next 10, 20, 30 years, where you think we should be directing our energy or what you think we need to understand more about.
Yeah. Great question. I think focusing on just pre and post adolescence is particularly important. Again, my wife's a developmental
Yeah,
psychopathologist, and in her trials, she can take kids at elevated risk because they have parents with a history of depression and cut the risk of initial onset in half. And same kind of
crazy.
strategy we do for adults, but kids pick that stuff up.
Yeah. Yeah. What does that look like when she's working to decrease the risk? Is it behavioral activation and not trusting what you're thinking or any other interventions?
Exactly. And well,
Yeah.
those two catchphrases come from her.
Oh,
And
I love that.
yeah, and she also trained at Penn there with Marty Seligman, but they come from
Yeah.
her. Basically, adolescents can do all of that stuff.
Yeah. No, I love that. I took his class last semester. It was incredible. I got lucky because he hasn't taught undergrads in like 7 years, and I happened to be here when he was teaching undergrads. I was like,
Yeah, yeah,
yes.
yeah.
But no, I think she's absolutely right. And I think a lot of people underestimate how well adolescents can internalize skills from a mental health perspective. Like, if you can learn how to think about those things differently and how to manage your behaviors at that young age, you really are setting yourself up for success in so many ways. Because prior to that, it's like your environment and your schedule, which is largely determined for you, is doing a lot of the legwork. You're not really building those mental health skills. And so you have a lot of agency and capacity. And I don't know if we're trusting adolescents enough to be able to like remember and internalize and implement these things.
I think you're exactly right. Our experience has been that there's nothing an adult can do that an adolescent can't do. The real change comes pre-adolescent opposed to into adolescence. From 11, 12 on, it's just miniature adults.
Yeah, yeah. I love it. Well, if people want to continue to keep up with your research, where can they do that?
I have a website at Vanderbilt, and we
Perfect.
publish periodically. When you took the class, was that with DeRubis or Seligman?
We took it with Dr. Seligman. He did
Yeah.
the lectures for every single class, and he had brought in a bunch of MAP graduates as TAs, so it was really incredible.
He was one of my, I think it was one of my three mentors, along with Tim Beck and Jerry
Yeah.
Clever, my wife's primary mentor.
Oh my
Uh,
gosh, that's incredible.
he's absolutely marvelous. And he and Steve Mayer did a paper, came out in 2016, where essentially they said we got helplessness, learned helplessness all wrong.
Yeah. Yeah.
Marvelous thing. And most scientists make their theories more complex when they're conflicting data. These guys said, no, we looked at it and we had it turned upside down. And they, and you don't find many instances of that kind of courage in the sciences, but bless his heart for doing that. He always used to say that in science, the goal isn't to start right, it's to get right. What a great role model for that.
Yeah. No, we did the last couple classes on AI and where he wanted to see the field going and
Yep.
international conflict. Like, he's very much early adopter, thinking ahead. It's really, really incredible.
Yep. 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 Marvelous.
It's amazing. Well, thank you so, so much for taking the time. Thank you so much for listening to this week's episode of She Persisted. If you enjoyed, make sure to share with a friend or family member. It really helps out the podcast. And if you haven't already, leave a review on Apple Podcasts or Spotify. You can also make sure to follow along at She Persisted Podcast on both Instagram and TikTok, and check out all the bonus resources, content, and information on my website, shepersistedpodcast.com. Thanks for supporting, keep persisting, and I'll see you next week.